Chest pain, either pleuritic or non-pleuritic, can be a prominent feature, and when coupled with hemoptysis, so chest pain with hemoptysis, usually as an emergency physician, I'll think of pulmonary embolism, right? This can be misdiagnosed as pulmonary embolism also. And shortness of breath, usually patients, around 30% of the patients will complain of shortness of breath as well. So a patient coming with chest pain, hemoptysis, shortness of breath, usually I'll think of pulmonary embolism in this kind of patients, right? But your CTPA is going to be negative here. And gastrointestinal difficulties are often pronounced. Abdominal pain, nausea, vomiting can occur in up to 20% of patients. And diarrhea, watery diarrhea is reported in around 50% of cases. So the most common neurological abnormality is altered mental status, especially if it's coupled with high temperatures, because the temperature can go as high as 104.9 degree Fahrenheit. Okay, in around 20% of cases, that is every 1 in 5 is going to have this kind of high degree of temperature. And chest examination reveals rales early in the course and evidence of consolidations as the disease progresses. And abdominal examination may reveal generalized or localized tenderness only, but not any significant issues. So remember, in a review of 13 studies of community-acquired pneumonia, clinical manifestation that occurred significantly more often in Legionella disease are the diarrhea, neurological finding, and temperature. Okay, so having seen about listeria, our previous topic, even that presents with diarrhea, neurological findings, and temperature. So even here you have diarrhea, neurological findings, and temperature, right? So you need to be able to differentiate what you're dealing with. And both the diseases is not primarily a CNS disease, it's infections basically. Hyponatremia, elevated values of LFT, hematuria can also occur in Legionella disease. And of course, there are other things which you need to remember. It's a creatine phosphokinase elevation, hypophosphatemia, can be an AKI, proteinuria, all this can occur in Legionella disease as well. Extrapulmonary Legionellosis. Since the portal of entry for Legionella is the lung, anything which goes extrapulmonary should be a blood-borne dissemination from the lung. Okay. So in a prospective survey of patients with Legionella disease, diagnosed by isolation of organism from the sputum, the Legionella was actually found in blood also, that is from bacterium also persisted for nearly 40% of cases. If there is a sputum positive Legionella, that can spread in the blood up to 40% of cases. Once it is spread through the blood, it had to be identified in lymph nodes, spleen, liver, kidney in autopsy samples. And the most common extrapulmonary site of Legionella is the heart. Okay, once I say it has reached the heart, the patient can have myocarditis, pericarditis, post-cardiotomy syndrome, prosthetic valve endocarditis, all these things can occur. And remember, most cases have been hospital acquired. Okay. In some patients without overt evidence of pneumonia, the organism may gain entry through a post-operative sternal wound exposed to contaminated tap water, or through a mediastinal chest tube drain insertion also. Okay, sinusitis, peritonitis, pyelonephritis, skin and soft tissue infection, septic arthritis, pancreatitis also has been associated with this kind of infections. So this is a baseline chest X-ray of a 52 years old male who is a chronic smoker. Okay, this is only baseline chest X-ray. So this is on admission, that's on presentation. A 52 years old male who is a chronic smoker has now come to you with a fever, cough, with non-productive sputum, and this is an X-ray. Okay, so once I tell you that a patient is a smoker, it means the ciliary mechanism is lost, right? And the patient is having fever, and the patient is quite sick, quite toxic. Look-wise is very toxic, and X-ray is showing features of significant consolidation, right? And see here, that's multilobar consolidation. It's on the bilaterally, right? That's multilobar consolidation, and it's a non-productive sputum, right? So all these things tells me that this is Legionella. This could be Legionella, right? Atypical pneumonia could be Legionella. Okay, so we started them on treatment. Day 3 of treatment, actually, the disease appears to be worsened. Okay, this is a usual pattern of Legionella, dear friends. Even if you start treating the patient in a day or two, the clinical picture, I mean the X-ray wise, you will see some kind of worsening, and then only the patient improves. Moreover, the clinical improvement will be preceding, and the X-ray improvement will actually lag a little in Legionella. So all patients with Legionella disease have abnormal chest radiograph showing pulmonary infiltrates at the time of clinical presentation. Remember, even at the time of presentation, they will be quite sick and toxic, requiring ICU admission. In a few cases of hospital occurred disease, fever and respiratory tract symptoms have preceded the radiological evidence of infiltrate. If it's a hospital occurred, patient becomes sick, X-ray may be normal in the first point. Okay, if you repeat the X-ray after 2 to 3 days, you will find a patch. Findings on chest radiograph are useful for assessing the severity of illness and to identify it is a multilobar involvement or not, and you can even monitor whether the patient is improving or worsening. Okay, so however, these findings are usually non-specific and they don't differentiate whether it's a Legionella or other pneumonia just by seeing the X-ray. Okay, you need a history, clinical examination, and a documented evidence to the sputum. Okay, and pleural effusion is evident in around 63% of patients on hospital admission. In immunosuppressed patients, especially those receiving glucocorticoids, distinctive round nodular opacities may be seen. Okay, these lesions may even cavitate, they may even expand. Okay, likewise, abscesses can occur in immunosuppressed hosts. The progression of the shown infiltrates and effusion on chest radiograph despite appropriate antibiotic therapy within the first week is very, very common. Okay, even if you start the patient on antibiotics, to reach in the lung, to have effect on the chest radiograph, to have effect on the particular patch is going to take some time. Okay, so during the first 1 week, the progression of infiltrates can be seen in the X-ray, even if you have started the patient of appropriate antibiotics. Okay, radiographic improvement lags behind the clinical improvement by several days. Understand this. Okay, very important. Don't keep changing your medication. Complete clearing of infiltrates requires around 1 to 4 months. So how to diagnose this? So you can do a sputum culture and it has a sensitivity of 80% and specificity of 100%, or transtructal aspirate. Sensitivity is 90%, specificity is 100%, or direct fluorescent antibody staining of sputum with a sensitivity of 70%, specificity of around nearing 100%. And these are all about sputum samples. We have an easy test. Okay, urinary antigen testing. Though the sensitivity is 70, but specificity is 100%. Okay, and antibody serology, sensitivity is 60% and specificity is 100%, nearing 100%. Okay. Because clinical manifestations are non-specific, because the patient comes with fever, constitutional symptoms, and the chest X-ray shows a patch. Okay, so with this you cannot diagnose as Legionella, right? You can only assume, you can have a differential diagnosis of Legionella because of atypical presentation. But to diagnose this to be clinically proper Legionella disease, you need some microbiological test. So the sensitivity of bronchoscopy specimen, whether you do a bronchoscopy or you do a mini ball or you whatever the patient brings of the sputum, they're almost equal in terms of if you can grow that particular organism in a selective media. Okay, if the sputum is not available, then do a bronchoscopy and take a specimen. Okay, bronchoalveolar lavage fluid gives higher yields than the bronchial wash specimen. Or if the patient is having a pleural effusion, you can drain it for a diagnostic purpose. In that fluid, you can do a DFA staining culture and antigen assay as well. So staining, gram staining of material from normal sterile sites such as the pleural fluid or lung tissue can suggest the diagnosis, because these are all sterile sites, right? If the bug is showing a gram positive bug in a atypical pneumonia presentation, then this could be a Legionella. But if you try to detect the Legionella specifically in this kind of gram stain, you will be able to see only the leukocytes. Okay, you may not be able to see Legionella because they are very small and you need a larger quantity of Legionella to be visualized in the gram stain in the first place. Okay, so when they are visualized, the organism appear to be small, pleomorphic, faint gram-negative bacilli. So extremely difficult to actually identify in the gram staining at all. Okay, so can you see that? It's going to be very, very small in quantity. Sometimes this can be misdiagnosed as tuberculosis because Legionella mygdalii organisms can be detected as weakly or partially acid-fast bacilli in clinical specimens. So modified acid-fast staining usually substitutes 1% sulfuric acid for the traditional 3% hydrochloric acid. So this kind of substitution makes the less aggressive decolorizer so that there will be better yield of gram-negative organisms. Okay, so that can show you that Legionella mygdalii. Okay, Legionella infected patients have occasionally been treated empirically with anti-tuberculous medications because of such false positive acid-fast smears. So DFA test is rapid, highly specific, but is less sensitive than the culture, because for a DFA to identify an organism, there should be adequate amount of organism, right? You need a large amount of organism to actually see microscopically, right? So this test is usually done in advanced stage than at the early stage. So whenever you are ordering for a test, you need to understand whether this test can prove positive or not on the first place. Okay, so culture, the definitive method for diagnosis of Legionella infection is isolation of the particular organism from the respiratory secretions or any other specimens like pleural fluid and stuff. So multiple selective BCOE media contain dyes and other antibiotics encoded in that particular medium itself for maximal sensitivity. Colonies usually grow very slowly, requiring around 5 days to become grossly visible. Okay, so wait for the cultures to grow. So when culture plates are overgrown with other microflora, pre-treatment with the specimen with acid or heat can markedly improve the yield by suppressing the other microflora. Okay. So Legionella pneumophilia is often isolated from sputum that is not grossly or microscopically purulent at all. So patient will be more sick, the patch is going to be big, but the patient will not be able to bring out much of a sputum at all. Okay, so that tells you that's more of a atypical variety, possibly Legionella. Moreover, whatever sputum the patient is bringing out, it will look as if like a contaminated sputum only. Like even you split it from your oral cavity. Okay, it will have more than 25 epithelial cells per high power field, right? So if at all your sputum sample contains 25 epithelial cells per high power field, you usually assume it to be contamination, right? Even in such kind of samples, you will still be able to see a pneumophilia. Okay, you need to just identify the correct method to detect that particular bug, but the bug will be present. So antibody detection, antibody testing of both the acute and the convalescent phase sera is actually necessary. A fold-fold rise in titers diagnostic. 12 weeks are often required for the detection of an antibody response. 12 weeks. Okay, so you can't wait for 12 weeks to diagnose a patient, right? So usually this is used for epidemiological purpose only. Okay, so a single titer of 1:128 in a patient with pneumonia constitutes a circumstantial evidence of Legionella disease. So this is about the sputum samples, right? So easy to do test is good by urinary antigen test. Okay, it's basically a non-invasive, right? So because when the sputum, there is not enough sputum sample, you need a bronchoscopy to take the sample out. Instead of going for a bronchoscopy, better doing a urinary antigen test is quite easy, right? So the assay of Legionella soluble antigen urine is rapid, relatively inexpensive, easy to perform, and is second only to the culture in terms of sensitivity and specificity. Okay, so several enzyme immunoassays and a rapid immunochromatography assay are actually available for this urine antigen testing. So this urine antigen testing is available only for this one species, the Legionella pneumophilia serotype 1. Okay, this actually causes more than 80% of Legionella infections. Of course, there are some cross reactivity, but still, if it turns to be positive, you can consider Legionella pneumophilia as your diagnosis. So cross reactivity with other Legionella pneumophilia serotypes and other Legionella species is detected up to 22% of urine samples from patients with culture proven cases. Okay, but antigen in the urine is detectable 3 days after the onset of disease. Okay, this is also very important. You can't do it at the day 1 and usually can disappear over 2 months. So if the patient is discharged and the patient comes back to you within a week or 2, if you repeat the urine sample for the urine antigen, it can still be positive because it takes really 2 months for the urine antigen to disappear. Positivity can be prolonged when patients give on glucocorticoids. Okay, and very, very important, this is your exam question, dear friends. This urine antigen test is not affected by your antibiotic administration. There are other molecular methods like PCR with DNA probes is theoretically more sensitive and specific, and there are other molecular probes being evaluated and will come to market. So now you know about the Legionella disease, and it is in the lungs and it has gained access into the body and is creating some atypical presentation of community acquired pneumonia. Okay, and you have hospital acquired pneumonia because of Legionella as well, and you know how it occurs. Coming to the pathology, the consistent pathological feature of Legionella disease actually are considered the lungs. Multifocal pneumonia with patchy lobar inflammation, extensive multilobar consolidation have been observed. Okay, so it's going to be a dense pneumonia. It's usually a multilobar pneumonia, and the inflammation is going to be quite severe. Because of the inflammation, the patient is going to look more sick and more toxic. Okay, so visible abscess with central necrosis are seen in 20% of autopsy cases in one study. So such severe is the disease, right? So on histological examination, fibrinopurulent pneumonia with intensive alveolitis and bronchiolitis was also evident. So because Legionella is an intracellular pathogen, whatever antibiotic you are going to give should reach the intracellular area with higher concentration more than the MIC, more than the minimal inhibitory concentration. Okay, so these are the antibiotic of choice. You can give macrolides, you can give quinolones, ketolide, tetracyclines, or others. So macrolide you can, for atypical pneumonia, usually we start the patient azithromycin, right? 500 mg per oral or IV Q 24th hourly. If the patient is quite sick, you can go ahead with IV also. Clarithromycin 500 mg per oral or IV Q 12th hourly. Quinolones, levofloxacin 700 mg IV Q24th hourly or 500 mg per oral Q24 hourly. Ciplox, ciprofloxacin 400 mg IV Q8th hourly or 750 mg per oral Q12th hourly. Moxifloxacin 400 mg per oral Q24th hourly. For ketolide, telithromycin we usually won't use that. Tetracycline, doxycycline 100 mg per oral or IV Q12th hourly. Okay, we usually use doxycycline or azithromycin, right? So minocycline 100 mg per oral IV Q12th hourly or tigecycline 100 mg IV load, then 50 mg can be used. Okay. Others like trimethoprim sulfamethoxazole and rifampicin can also be used. So here among all things preferred, we usually prefer this kind of quinolones, right? Quinolones are preferred antibiotic for transplant recipients because both the macrolides and the rifampicin interact pharmacologically with the cyclosporin and the tacrolimus which is given to the transplant patients. And retrospective uncontrolled studies have shown that complications of pneumonia are fewer and clinical response is better in patients who receive actually quinolones. Okay, and moreover the telithromycin are highly active in vitro and in intracellular models, but clinical experience less extensive than that of the macrolides and quinolones. So alternative agents is your tetracycline, doxycycline, minocycline basically. TG is active in vitro, but clinical experience is quite lacking, but on case-to-case basis, TG is also working fine. Anecdotal reports have described both success and failure with the trimethoprim sulfamethoxazole, imipenem, clindamycin and stuff. For severely ill patients with extensive pulmonary infiltrates, a 2-drug combinations of a newer macrolide or a quinolone with the rifampicin may be considered. Okay, and if the patient is sick, always start with the IV route. Okay, don't start with oral route. Moreover, this patient, this kind of Legionella pneumonia, even at the day of presentation to your hospital, so the patient will be quite sick and require ICU admission. So start the patient IV route rather than an oral route. A clinical response usually occurs within 3 to 5 days. Till that 3 to 5 days, you can see the pulmonary infiltrates getting little worse. The patient can go little toxic as well. After which the oral therapy can be substituted. The total duration of therapy in immunocompetent host is around 10 to 14 days. Okay. Sometimes in immunosuppressed patients or patients who are coming with an advanced disease, you may extend this for 1 more week as well, like totally of 3 weeks. Okay. For especially azithromycin, usually it has a longer half-life, so you can give for just 10 days and stop it. So coming to the 2 diseases, the Pontiac fever and the Legionella disease. So Pontiac fever, as I told you, it's an acute self-limiting fever, right? So Pontiac fever requires only symptom-based treatment and not a antimicrobial therapy basically. So prognosis, mortality rates for Legionella disease varies with patient's underlying disease and its severity, patient's immune status, severity of pneumonia, and timing of administration of appropriate antimicrobial therapy. Okay, how early the patient comes to your hospital, how early you identify and how early you start the treatment all matters. Mortality rates are highest 80% among immunosuppressed patients who do not receive antimicrobial therapy early in the course. Okay, but if at all, if you give an appropriate and timely antibiotic treatment, this kind of mortality rate from community acquired Legionella disease among immunocompetent patients can be brought down to literally 0 as well. Okay, so without treatment, mortality is as high as 31% immunocompetent patient. So for immunocompetent patient, mortality is 31. If you start treating them, it can come down to 0. For immunosuppressed, if you are not treating properly, 80% is going to be the mortality rate. So how are you going to prevent the Legionella disease? So now you know what is the pathogenesis and how you are going to treat it, right? So routine environmental culture of hospital water supplies is recommended as an approach for prevent hospital-acquired Legionella disease. So guidelines mandating this kind of proactive approach to check the water bodies in the hospital and institutions are being adopted in many countries, Denmark, France, Germany, Italy, Netherlands, and even India is slowly moving towards this kind of proactive movements. Positive cultures from the water supply mandate the use of specialized laboratory test, especially on the BCOE medium, the selective media, and the urinary antigen test for patients with hospital-acquired pneumonia. Okay. So once you identify that the water supply is being infected with Legionella, disinfection of the water supply is now actually feasible by 2 methods. Okay, one is the superheat and flush method. So heat the water to a maximum temperature and flush it out. Okay, that's called superheat and flush method, which requires heating of the water so that the distal outlet temperature is 70 to 80 degrees Celsius and flushing of the distal outlet with hot water for 30 minutes. Okay, so when there is a water reservoir and it is infected with Legionella, usually we don't take samples from that particular reservoir and check for improvement, right? it's having 10 pipelines. We usually go check the distal all the 10 pipelines and check for positivity of Legionella there, right? So because biofilms can form everywhere, right? So only cleaning the reservoir is not going to help you, right? So this is one technique where superheat and flush technique, where you increase a distal outlet temperature to 80 degrees Celsius and flush it out for 30 minutes. A commercial copper and silver ionization method has proved effective in numerous hospitals. So carbon dioxide and monochloramine are undergoing evaluation and preliminary results are promising. So tap water filters have been effective for high risk patient areas such as the transplantation units, and hyperchlorination is no longer recommended because of its expense, because of carcinogenicity, corrosive effects on pipeline, and unreliable efficiency. Okay, so now you need to look into both Listeria and Legionella, because these are the things which is usually confused. Okay, so sticking on to Legionella, so this causes two different disease patterns. One is the Pontiac Fever and next is the Legionella pneumonia. The Pontiac Fever is actually a self-limiting form of disease, right? So acute febrile illness, right? It usually comes in outbreaks. It's airborne spread. It's more than 90% is going to be the attack rate, right? So, but it's self-limiting. We are not much worried about it. The second is going to be the Legionella pneumonia. It's a type of atypical pneumonia. Patients come with all the constitutional symptoms along with significant cough, chest pain. X-ray may show a patch, but decreases sputum production, non-productive cough, and it's less likely to be purulent as well, right? Patient may look more toxic because of the inflammation. Patient can have hematemesis. Don't diagnose this as pulmonary embolism there. Okay, don't thrombolize this kind of patients. And once you take a chest X-ray, you will note there's a multilobar involvement. A dense consolidation will be there, right? And moreover, the first level of defense is going to be the mucociliary defense. If the patient is a chronic smoker, or because of any COPD, or the patient is an alcoholic, this kind of first defense is broken. Neutrophils has no big role. Macrophages, they engulf this particular bug, but they fail to generate oxidative burst. Okay, so cell-mediated immunity can kill those cells, and humoral immunity takes a big toll. Humoral immunity can control this kind of infections, right? So if the immunocompetent patients are not treated properly, mortality is 30%. If treated, it can be brought down to 0. Immunodeficiency patients has a mortality of around 80%, right? So cell-mediated immunity can kill and control this kind of cells, which is infected with the Legionella. So patients who have cell-mediated deficiencies, T-cell deficiency, are more prone to develop this kind of infections. Moreover, initially it was thought that it is the cooler tower, it was a water reservoir in the industrial and residential areas, which is causing this kind of Legionella. But later it was diagnosed as the potable water, the drinking water, okay, not the industrial water or the reservoir or AC air cooler water. It's basically the potable drinking water. There are various routes of transmission. The major route is going to be aspiration, either from the oropharyngeal colonization or by drinking the contaminated water and getting regurgitation. And this kind of aspiration is more prone in general anesthesia, head and neck surgeries, patients who are continuously a longer time intubated, unsedated, patients who are on Ryle's tube managements, right? You need to identify with proper diagnostic techniques, okay? Either you can go for a lung specimens like sputum specimen, bronchospecimen specimen, bronchial wash, because there's non-productive, right? It's required a technique, it requires proper personnel to do a bronchoscopy, right? It has financial implications as well. Or you can go ahead doing a urinary antigen test, which is non-invasive, easy to perform. Reports will be readily available as such. Of course, it is less sensitive than a culture method, but still it's promising, right? So if it turns to be positive, you can start treating the patient. And you know what set of drugs to give and how long to give. And you know that initially when you start treating the patients in a day or two, maybe in even the first week, you will see that just X-ray wise the patient may be worsening. The inflates may get little worsen. Okay, that's how the usual first week will be. And moreover, clinical improvement will be better and preceding than clearing of the X-ray. The X-ray infiltrates will take some time. It will lag the clinical improvement. So initially the patient starts clinically improving, and only then the chest X-ray will seem slowly to improve. Okay, so don't change the drug, right? So how to prevent? So you need to take all the prophylactic measures, especially in the hospital associated area, and you need to check periodically the hospital reservoir of this water reservoirs, air cooler towers, and the distal taps. And if it's positive for Legionella, you know two methods. One is the superheat and flush method, and other could be the carbon dioxide monochloramine method or the copper and silver ionization method. Okay, so this is the way to diagnose. And moreover, the lung pathology can go ahead with cavitation and abscess formation. So it's going to be very severe. Then once formed, it can take a longer duration for the lung to come back to normalcy. Okay, so you need to start the treatment at the earliest. You need to identify the possible differential diagnosis at the earliest of this kind of atypical pneumonia and start the patient on appropriate antibiotics at the earliest. Okay, thank you.